Levinsky. Please go ahead.
Hi, I'm Julie Levinsky, Web Manager for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to our I'm rushing, August edition of our live chat with Nurse Linda. I would tell you a little bit about Linda. She is a leader, a teacher, and a provider of rehabilitation nursing for over 30 years. And in fact, Nurse Linda has worked closely with Christopher Reeve on his recovery and has been advocating for the Reeve Foundation ever since. And in our community, she is the moderator of the Ask a Nurse discussion, which she focuses on contributing functional advice, providing the how-to and integrating various healthcare improvements into daily life and answering your specific questions. And you can find her online in the community at christopherreeve.org/nurse. And she's so graciously once a month offered to talk for an hour answering your questions in a live chat. So now I'm going to turn it over to Linda. Hello, Linda.
Hello, Julie, and good afternoon, everyone. I'm so happy you could join us today for the webinar. I've been doing a series this month on pain, and as we know, if we look at any of the literature out there, if you talk to people, a great number of people who have spinal cord injury or disability also have pain. And sometimes the pain is unique to the spinal cord injury. I can say that in life, in general, every single person on the planet, save for a few people, everybody feels pain at some time or another. And there's all different kinds of pain. So this week's series, or this month's series, has been about some of these different kinds of pain and the way you can treat them, and some new things that are coming in the way of pain research. So if you think about pain, if you have any kind of discomfort, something that's uncomfortable, that is really some sort of manifestation of pain. Now, if we have a little itch, or sometimes, we might be sitting leaning up against our elbow like I am right this minute, which makes me think of that, so I'll stop that. But you might be leaning up against your elbow and it might start to just feel a little uncomfortable. That's the beginning of pain. Pain is actually a wonderful gift that has been given to us that alerts us that something is wrong and we need to make some kind of an adjustment. It's hard to think of pain as being a wonderful gift, but it actually is. In fact, there is a person who wrote a book about the gift of pain and how pain saves us from a lot of different kinds of problems that we may have. So if I would continue to rest my body weight on my elbow, it would start to get a little more painful and even a little more uncomfortable. And so it's a signal to me that I need to get some of the pressure off of that. Sometimes after spinal cord injury or disability, you might not feel that pain, so you might not get that feedback. So if you stayed with pressure on your elbow, you could get skin breakdown or other kinds of problems. So it is kind of a nice system to have in place. Now there are different kinds of pain. So most everybody has felt muscular pain. And I think individuals who are using different mobility devices may experience this. We all experience muscle pain when we overuse our muscles. If we're exercising, you might feel, you might think, wow, I got a little uncomfortable with that. Or as the expression goes, if you don't, you have to feel the burn, which is not really entirely true. But, there's all kinds of expressions that go with over-exercise or overuse of our body parts, and that's usually muscle pain. So our muscles get weary, they get overused, they say, I've had enough, stop for a while, let me rest and rebuild myself, and recover from the extensive use. If you're pushing a wheelchair, a lot of people have shoulder pain because, people want to go fast. No matter how you're getting along, people like to move quickly. So people tend to reach back really far to get a good propel on their wheelchair wheel, and they shoot across the room, which is nice for speed, but sometimes that pulling back too far can make your muscles uncomfortable, or it can even cause joint pain because you've overstretched that joint a bit. So muscular pain is one kind of pain. Referred pain is another type of pain. It's in a different classification. And referred pain happens when we have some pain in our body, but for some reason the message can't get to our brain correctly. So the most common type of referred pain is somebody who is having a heart attack. We've all heard of people who have referred pain while they're having a heart attack, and the heart can't communicate that it's having a problem. Our internal organs don't have the same kind of nervous system that our external body has, because our external body is up against the elements of the world. Our internal body is protected by the nerves and muscles and the bony structure of our body. So internal organs don't quite have the same type of nervous system structure that our external body has. But so referred pain in a heart attack, people will commonly talk about pain radiating down the left arm, or feeling left shoulder pain, maybe feeling like they have an upset stomach, so kind of getting some epigastric pain. So people have all heard of that kind of pain. After spinal cord injury, referred pain can be a little bit different, because the body below the level of the spinal cord injury still has ability to work, still has the ability to function. It's just not getting messages from the control center of the brain to do those activities. So if you have, say, if you're feeling in your mind, you feel like you have a pain in your leg, and you think, well, that's kind of counterintuitive because I don't have sensation below the level of my spinal cord injury, so how can I be feeling pain in my leg? That might be a referred pain that you're getting, where there's some message of pain that's being transmitted up the spinal cord. It gets kind of interrupted where that spinal cord injury is, so that nerve message is going to try to find a way. It's trying to get to the brain, because that's the way the nervous system works. Messages from the body try to get up to the brain, and the body responds by getting messages relayed back down into the body. So that there's some problem going on. You feel like, oh, I have pain in my leg. You start kind of inspecting yourself, seeing what's going on. Oh, it was a kink catheter. So probably it was a pain from the bladder that was being sent, but it got misinterpreted in the brain as a pain in the leg. After spinal cord injury, most of the referred pain will appear in your shoulder, across your back. And the reason this is because right there at that T4 where the autonomic dysreflexia kind of all comes into play, there's a nerve bundle there where a lot of nerves come very closely together. So messages, those chemical messages, are easily able to skip around when it gets to that place. That spot is also close to our shoulder, and that's why we often feel pain in our shoulder after a spinal cord injury. That's someplace in your body, so you have to search for that. Another good example of referred pain is if you've ever just had the feeling like your teeth hurt. Every single one of your teeth hurt in your body. And you think, well, my teeth can't hurt because, they've got that enamel on there. What's going on? Sinus infection will cause some inflammation in your sinuses, which presses on those nerve roots, which makes your teeth feel like they're hurting. So if you've ever had a sinus infection, you might have felt that kind of referred pain. And then the third kind of pain is neuropathic pain, and that's the kind of pain that people with spinal cord injury have such issues with, and that is the mistransmission of nerves firing in your body, so that you have these weird sensations of pain, and it's very hard to really see where they're going. The pain is actually not stemming from a muscle or an inflammation. It's just stemming from the nerves itself, because the nerves are irritated and they're trying to get some kind of attention. They're trying to tell you there's a problem here, and in your mind you think, yes, I know there's a problem because I have paralysis or I have spinal cord injury. Maybe I've had a stroke and I have some paralysis on one side of my body. And so that neuropathic pain is when those nerves are telling you there's some kind of problem, because they're not able to communicate with the brain to say, I have this understanding that this issue is going on. They just know something's not right, and they're trying to get that message to you. So why do we need to know about those different kinds of pain? Because the treatment for those are different. If you have muscular pain, you need to be treated for muscular pain. If you have referred pain, that's a different treatment. If you have neuropathic pain, that's a different treatment. So if you have neuropathic pain and the nerves are very hyperactive and you take medication for muscular pain, that's really not going to help calm those angry nerves. If you have referred pain, you need to find out what's causing that pain to be felt in a different spot from where the pain is actually occurring in your body, and get the original problem treated. So if you would take a nerve or a medicine for nerve pain or medicine for muscular pain, but you have a referred pain, it's not really going to help that referred pain because you're not treating the problem itself. So that's why we need to know what those are. And I think that really goes into our first question of the day, which is the different treatments for those different kinds of pain. So if you have a muscular pain, if you have any pain, there's kind of a hierarchy for treating pain. So if you have any kind of pain, the first process is going to be to try to eliminate the source of that pain. So when I'm back leaning on my elbow and it starts to get irritated, the first thing I do is take that pressure off my elbow, and that pain resolves. It goes away. It never got really bad. It's not like I would be going to my health professional because my elbow hurt. It's just a little bitty discomfort. And so you eliminate the noxious source, and the pain goes away, the irritation goes away, and you're like instantly all better. So that's kind of nice. Sometimes we overlook that lowest level of treating pain because it's just not in our culture to think about doing that kind of thing. Look for the simplest solution first is what we try to do. So if there's something that's bothering you, if you can just eliminate that. Now, thinking of that in the bigger picture, if you're getting a lot of pain in your shoulders from pushing your wheelchair, there's things that you can do to eliminate that pain. You can try to build up your muscles in that area to make your body stronger and able to compensate for the extra work that you have to do by using your shoulders for mobility. You might want to rest your shoulders for a while. You might need to take different rest periods in the day. Right at what we call the zone of transition, people tend to have a lot of muscular pain right there. The zone of transition is that place in the body where up above the zone of transition you have pretty much normal sensation. It might have some fuzzy sensation right in that particular area. And then below the zone of transition is where you have the deficit in your body and not being able to feel as well. You might not be able to feel as well. You might have some partial sensation, or you might have no sensation at all. And the reason why it's so difficult to accommodate that area is because the muscles below the level of injury, remember, are not getting that input, so they're not being triggered to work while you're sitting up or while you're doing activities. They're still there, they're ready to work, but they're not getting the message. So up above the zone of transition, you have the sensation, and your muscles are overcompensating for those muscles that are not working so well below. So a lot of people will have some difficulty right at that zone of transition. So there are things that we can do. We can help take some of the burden off those working muscles by putting our bodies in recline, even getting out of the chair for a while and taking a rest, positioning, using support devices. If you might use a harness to help hold your upper body up, If you are having problems and your neck is getting tired, maybe using a headrest to support your neck a little bit. So looking at what kinds of things can we do to really help relieve the pain. So some people will have a situation that's actually quite common if they're using a leg bag and the straps, when you put the leg bag on, they're perfectly fine because the leg bag's empty, and so the straps are just quite wonderful. But as the day wears on and the leg bag fills up, it becomes heavier and pulls on those straps of the leg bag. You might also be getting some dependent edema from your leg, from sitting up and having your legs being dependent away from your down south of your heart. So that makes the circulation harder to pump the excess fluid up out of your legs. So your legs are getting bigger, your leg bag's getting heavier, and those straps around your legs are getting tighter. You might not have the sensation to notice that that's happening, but your body might react in this referred pain sort of way, or you might trigger some neuropathic pain, in particular dysreflexia kind of pain. So what can you do about that? Well, the simplest solution is to leave your leg bag straps a little bit less tight. Maybe after a couple hours of wearing your leg bag, either drain it or make the straps less tight around your legs. So the first thing and the easiest thing to do is try to remove that stimulus that's setting your pain off. So that's kind of the very first thing to do. Then the next level of pain resolution is turning, of course, to some sort of medication. If you have muscular pain, if you're able to take Tylenol or the non-steroidal, like the Advil, Motrins, those kinds of medications. The simplest thing for muscular pain is some over-counter. If you are not able to take those medications, you might be able to take one kind but not another kind, and you'll need to work with your healthcare professional. Of course, for muscular pain, the easiest thing is to remove the stimulus, and the muscle pain will eventually resolve on its own. Sometimes, though, we have such severe muscle pain that we have to take a little bit something to take the edge off. But you don't need to be on that long term. You just need to wait until that episode resolves and then work on strategies to avoid that from happening again. Referred pain, of course, you want to treat the source of the pain. If you have that shoulder pain because you're having some kind of problem in your lower body, treating the referred pain as a muscular pain, taking some medication, maybe even a higher narcotic kind of medication will take away that pain in your shoulder, but it's going to come back because you haven't taken care of the source of the pain. So figuring out what the source of the pain is going to be is what the source of the pain is very important. And you need to work with your healthcare professional in figuring that out. You could be having a gallbladder attack, or you could be having a urinary tract infection or a respiratory infection. So really being able to note when your pain comes, what's happening. In a gallbladder attack, you could have a gallstone. You could have a significant gallbladder attack. Most people will feel pain in their side when they have a gallbladder attack. It's pretty significant pain. Not everybody. There's a very few number of people who will not have pain with gallbladder attack. But if there's a stone that gets caught in the bile duct, there will be, typically there will be some extreme pain. If you don't have sensation in that part of your abdomen, you might not note that you have that, but the stone could move and the pain could resolve until another stone is manufactured by your gallbladder, and then the pain comes back again. So noting when your pain occurs can be very helpful in figuring out what that referred pain might be. For instance, especially with the gallbladder, if you find that you have pain after the classic heavy, greasy meal, well, then you're having referred pain in your shoulder after that. It kind of gives you the indication to look for a gallbladder, because that's pretty easy to overlook, when you start looking inside the body when you can't really see what's going on. And so treating whatever the problem is for referred pain, it's going to take that pain away. And then the neuropathic pain, if you need to, you can try some different things for neuropathic pain. Now this I'm going to say with a bit of trepidation, because I don't want you to just go out and do this, but check with your healthcare professional first. Sometimes people will use a cool cloth, or maybe take a cooler bath, and that seems to help some people with neuropathic pain. I don't want you to just go out and do it, because you can get too cold, and of course you can get frostbite. So you need to be very careful in doing this. But there's some things you can do with neuropathic pain. One of the most common things you can do with neuropathic pain is to move the limb itself. Sometimes when we hurt, we don't want to move, but if we move that body part very gently, range it out, that might help reduce some of the fire in those nerves, because all of a sudden that nerve is getting feedback from the movement. And so it thinks, okay, something's happening here, and now this body part's moving and the nerve will quiet down. Now that's very simple, and it seems like, well, gosh, how could that possibly even be true? It does help, but it might not take it away. You might be past that kind of treatment response. So in neuropathic pain, there are medications that are prescribed specifically for neuropathic pain, and that's the gabapentin and the pregabalin. So looking at drugs like Neurontin and Lyrica are pretty much the only two drugs that actually treat pain from the nerve itself. You can take over-the-counter pain medications, analgesics, you can take narcotics. They will mask the pain in your brain, but the pain won't go away. And as we know, the narcotics are very addictive. So a lot of times people get so frustrated with trying to treat their pain that they'll turn to those, because it just kind of dulls the senses of the whole body, because it's working in the brain instead of on that nerve itself. It's difficult to treat neuropathic pain, because the medications that we have for treating that take a long time to build up in the body to make enough in the bloodstream to make them effective. So it usually takes about 6 weeks for those medications to work. That is a long time to wait when you're having significant nerve pain. And nerve pain may feel like electricity. It may feel like a knife cutting you. It's really pretty significant pain. So it's pretty hard to wait that long. Now, what they have found in the neuropathic pain, and what they used even before these other drugs that were specifically devised for treating nerve pain, is they have found that some of the drugs that treat seizures, the anticonvulsants, if they're taken in extremely low doses, so they wouldn't treat a seizure, there wouldn't be enough medication in your body to do that, but they will help neuropathic pain. Also some antidepressants, and some people are like, no, I don't have depression, I don't want to take antidepressants. But it's the same kind of thing. It's in extremely low doses that these medications will help with neuropathic pain. So there's a variety of medications that you can try for that, but there again, it's an extremely long time to see if the medications work. So suppose you take an antidepressant, or even one of the drugs that treat nerve pain itself. You start taking that, you have this neuropathic pain, you've tried the simpler method, so you've waited through that time period. Then you try these other medications and you have to wait 6 weeks, and say you don't get much of a result. People are ready to throw in the towel. They've been suffering with this pain for a long time. So what they will do, what they should do, is try to either up the dosage or try one of the other medications. But there again, you have to wait again 6 weeks to see if there's any kind of effect. Sometimes people will only be able to go a couple of weeks and they're like, listen, this pain is just too much. I can't take it anymore. I have to do something different. And you never really do find out if the medication worked or not, because that's not enough time to see. So Those are pretty much the medication routes. Now, for people who have irretractable pain, they've tried everything they can, they just can't seem to do anything. There are some surgeries that can be done. Oh, before we go to surgeries, though, there are some mechanical treatments that can be done, and there's a lot of things that are being done on the horizon that are helping pain also. So some of the mechanical treatments are things like using stimulators that are like a little device that, like the TENS unit that people put on. It's a little device that you wear. It's like a little transistor size. It almost looks like a cell phone or even a small cell phone. And you can strap that onto the area right where the pain is, and then an electronic signal will be sent through the skin into the body into that area. And that electronic signal will disrupt that pain message. And so those can be helpful. Now, there's no evidence, there's no research that I know of that's been going on, but it would be interesting to see, because I turn on my TV at night and there's commercials, and I have all kinds of celebrities who have pain from athletics or other kinds of problems, and they're trying these little TENS units that you can just go buy in the store. We don't know what kind of effect that would have on people who have decreased sensation, how that would affect their pain, or how it would affect their skin, or what that might do to a person who has decreased sensation. You could end up with some kind of, perhaps a burn, or just any kind of complication. Because we don't know what those would do. But since it helps people with like some pain, lower back pain, maybe it would help people with spinal cord injuries. So you might want to talk with your healthcare professional. And if you have somebody who's supervising that for you, I would not recommend going out and doing it on your own, but if somebody's supervising that for you, it might be an opportunity to do something. There are other kinds of medications that can be injected or taken by pills. Sometimes the pain is the neuropathic pain is coming from spasticity of your muscles, and your muscles are built to counteract each other. So there's, in your body, wherever there's a muscle for pushing, there's a muscle for pulling. The pulling muscles will be oftentimes stronger than the pushing muscles. So if you think of people who have gotten contractures from not being able to move their extremity in some way, the contracture always draws the extremity in towards the body. Those pulling muscles are the stronger ones. It's harder to extend your arm out than it is to draw it into your body. So some people will take Botox injections to reduce some of that pulling towards your body, and then that releases some of the busyness of the nerve to send that signal of the spasm or contraction that's forming. So sometimes people will do that. Baclofen is a drug that has been taken for different kinds of spasms, and with spasms, the pain that goes along with that. There is some evidence, and it's significant enough that people are paying attention to this research, that that drugs like baclofen can stop nerve regeneration. So sometimes when the nerves are regenerating and they're growing and they're forming new junctures, because our nerves regenerate in our body. It's just like our skin does, but it's a very slow process. So sometimes with that regeneration, there's some pain, and if you take some drugs, that might stop the regeneration from occurring. So sometimes when I have patients come in and they have some pain in a particular part of their body, it again is kind of one of those double-edged sword gifts of, gee, they're having regeneration, but the regeneration hurts. But the regeneration is improvement in their spinal cord injury. So it's kind of hard to share that with people, and because you want them to be comfortable, but you have to be able to tolerate the regeneration also. So There are different other treatments that can be used. Sometimes people will have a pump put into their body that bathes the spinal cord with medication. That is more medication than you can take by mouth. When you take medication by mouth, it goes into your stomach and goes through your gut, and so it breaks down in there, and sometimes people can't tolerate that large amount of medication that they need to control their pain. So a surgical procedure that might be done is to implant a pump that is a little, it looks like a little pacemaker. It's put in the abdomen, and medication is injected in there at regular time periods. And the medication goes through a little tube that's tunneled underneath the skin, and it actually goes into the same column where the spinal cord is. It does not go into the spinal cord itself, but it bathes the spinal cord with medication, which calms these nerves from becoming overactive. So some people will do that, and then there's more extreme surgeries that are being done that will prevent messages from going through those nerves. The downside of that is that those nerves now have to be destroyed in some way, so that if you are a believer in regeneration or future holding, the near future holding some possible treatments that might help restore function, that kind of takes that piece away. Now, if you could also think, if this future of restoring nerves to function is out there, then if the nerve has been destroyed surgically, couldn't it then be regenerated through these same treatments? And that's a possibility too, but that puts an extra layer of confusion on there. So that's kind of the way the hierarchy of that goes. So let's just look here some more at some of the questions. We have a gentleman here who had some back surgery and has had some infections, and that he's looking for some assistance in New Jersey who can treat such a problem, and is there any medication? Well, actually you would have to check with your health care provider, but in New Jersey there are many people who are specialists in spinal cord injury. So I think if you actually, Albert, if you contact our peer helpline or the people there at the Christopher Reeve Paralysis Foundation that can help you navigate in different parts of the country, they will be able to direct you in the right place. There's some very excellent, well-known spinal cord injury centers there. So if you get connected with a spinal cord injury specialist, they will be able to direct you to the people who are specialists in your particular problem. So that would probably be the best tactic to take at this point for your individual case, because there are people all over the country that would be able to help you, and certainly in New Jersey. I don't know about the particular county where you live, but in New Jersey there would be a cadre of specialists that would be able to help you with that. So that's good. You live in a good part of the country for that, so that'll be good for you. So if somebody is writing, and sometimes I get soreness in my scalp like it's tender. What could cause this? Well, okay, Julie, so that could be a lot of things. I don't know what level your spinal cord injury is. There are some people, now that treatment of spinal cord injury has become so extraordinarily good. When I first started my practice, you didn't see people with really high level of injuries, because if they had their injury out in the field, they usually didn't survive till help got there. Now we have such great medical care that a lot of people are surviving. So there are some people that actually have C1 level injuries, so they have abnormal sensation in their scalp. And so that might feel like tenderness or like being sore if you have an extremely high injury. Soreness in the scalp it could be from maybe, even a dermatological kind of problem, so it could be some kind of skin problem. Now, this is going to sound very weird, but we're going to talk about keeping things as simple as possible. Sometimes if you comb your hair a certain way, I mean, it sounds so crazy, but it's so true. If you comb your hair a certain way and then it gets messed up and it goes the other way, sometimes those hair follicles send off a pain stimulation. So it could even be something as simple as that, or it could be any kind of other kind of medical condition, or it could be if you have a spinal cord injury from a disease process, you could have some patches of decreased sensation all over in your body. And when you're in that zone of changing from having sensation to losing sensation, sometimes that feels like it's prickly. That might feel soreness. It might feel tender. So you need to check with your healthcare professional to see exactly what could be going on. It might be just something very simple that would be easy to take care of, and then again it might be something that might be a little bit more tricky to deal with. So look for the simplest first, and then go from there. Talk with your primary care provider. Do you need to see a dermatologist, or do you need to see somebody with a different kind of specialty area? So here's a person that's asking if you have a bulging disc in the very lower back with no spine impingement. Very lucky. But still, probably that bulging disc is pressing on the spine, the nerve root that's coming out of the spine. That's usually what happens. The way the spinal cord is set up is, you have those bony vertebrae, and then you have the spongy disc that goes in between each vertebrae. Now, most of the bones in our body are long and solid. If you think about a bone in your arm, it goes from the elbow to the wrist. It's a long, solid bone. If you think about a bone in your leg, it could go from your hip to your knee, or you have two bones that go from your knee to your feet. They're long, solid bones for supporting the body and keeping us upright, being able to get up and move around. But our spine is a little different because you have all of these bones that work together as one unit. So you have the spinal column, but it's not one fused bone. It's made up of all these different vertebrae. And the reason for that is we need that for our balance. So that helps us hold up the trunk of our body, because we have a lot of weight up in our trunk, in our abdomen, in our chest area along our back. So the spine is articulated with these little vertebrae, and out of each of those little vertebrae come some nerves that spread out and go around horizontally, going across your body. So that's the way the nervous system and the bony skeleton work together. So to keep those bones, those vertebrae from bumping up against each other, there's the disc, which is a spongy substance. It's in the inside the disc. It's really kind of more of a liquid, and it's very viscous. So it's a very thick liquid. It moves like molasses. If you've seen molasses move, it's a liquid and it moves, but so slowly. It's even thicker than syrup. So it's really, really, it's really thick. So the disc is contained with this thick liquid inside of it. And so sometimes what happens is it gets a little outpouching on it, and so that disc will swell out of its space. That liquid then goes into that outpouching, and it presses up against a nerve coming out of our spine. So that's what causes the pain. So it's not in the spinal column, but it's just irritating that nerve just enough to be extremely painful. So what you need to do is to get that liquid back into its chamber where it belongs and get it reduced from pressing on the nerve. So some people do take cortisone injections to reduce the swelling. There are complications from cortisone injections in that there is a relationship with cortisone injections eating away some of the bony skeleton, particularly in the hip. So there's people are starting to notice a correlation between having steroid injections and needing to have a hip replacement. Who knew? But there you go. And then trigger point injections work more at the surface of the nerve, so more the trigger points are more towards the surface of the skin rather than deep in next to the spine. So depending on what's causing that impingement would depend on which one of those processes you would want to have. There is an abundance of evidence now that is demonstrating that with physical therapy, there are things that you can do to help reduce sorry, I lost my train of thought, that can help the disc get back into this place. There's some exercises that you can do. They can provide some therapy treatment which will help that very thick viscous substance go back into where it belongs and reduce that. The evidence now, the research now demonstrates that that can be just as effective as surgery or some of these other treatments. And so it's really coming into its own. The downside of that is that it's time. It takes a lot of time to do these exercises. It takes a long time to see some results. So some people don't want to wait that amount of time. You know, they're in pain and they want treatment right now. So I would be sure and talk to your specialist and see the cortisone, if the problem is the disc bulging and hitting the nerve at the root where it comes out of the vertebrae, that would probably be appropriate. If it's more a kind of thing where you're having surface nerve problems, which wouldn't be quite so much from the nerve, from the disc, but if it's surface root, then trigger points are more probably more effective for that. But there are therapies, and then there's also, if the disc bulges enough, some people will resort to the surgery. But if it's in such a place that you can go ahead and do the therapy, many people are having a lot of use with that. And so let's see. Back to our person. Oh, I think Julie with the scalp problem. She says it's the shoulder and not the scalp. Autocorrect, don't you hate that? So she's been using a TENS unit and it works wonderfully. So that is great. So it sounds like you've got that figured out. If it's taking away the pain, that's fine. If it's, you need to work with your healthcare professional if you're having shoulder pain to figure out if that's coming from a muscular problem or if you're having referred pain or if it's a neuropathic nerve pain where the nerve is upset. The TENS unit will help make that pain go away temporarily, but if you stop using the TENS unit and it's caused from something else, the pain will still be there. So, but obviously to get the TENS unit, you are working with somebody, so be sure and talk with them about making sure. After a while, you should be able to turn the TENS unit off, and if the pain was treated by the TENS unit, the pain should eventually be gone. So we'll have to see how that works out because it sounds like you've got that under a good stead in getting that treated. Okay, so here I have a person who's a quad and getting a lot of spasm. He's losing weight and doesn't know why. I did blood work and it's all normal. Okay, so you're starting in, Robert, in figuring out what's going on. So, okay, so a lot of spasms. Well, I will tell you, spasms create a lot of energy in your body. Spasms, if they're severe enough, can cause you to lose weight because you're burning so many calories with your spasms. And so that's an entirely possible connection. Now, it's also possible when you're losing weight and you don't know why, it's also possible that you could have a metabolic problem. It is not uncommon for individuals with spinal cord injury to develop diabetes, not because of anything that they're particularly doing wrong in their diet, but it is because of the inability to move around, that you're not getting the activity needed to challenge your muscles to metabolize correctly, which is the reason why people with spinal cord injury tend to have more higher incidence of diabetes. So you had the blood work and it's all normal. So you would have to then you would probably eliminate the diabetes factor. Another thing could be if you're having some depression that can cause you to lose weight. But if we were just to look at just the information that you have in this one sentence, you could easily equate the spasms with generating enough energy, using enough calories to lose weight. So if you might want to speak to someone about helping you reduce your spasms. One of the things that you can do to help reduce spasms is to move your extremities. If you have a caretaker who can do some range of motion, that helps reduce spasms. If you have a spasm, you can stretch the muscles manually. You can have your healthcare professional show you how to stretch those muscles manually so that you can break the spasm so it will stop and your body will calm, and then that should help you in your weight loss. So I'm going to wish you well on that one, Gil. I think there's a lot of possibilities. You're well on your way in figuring out what's going on. So be sure and follow up. You had your blood work. Be sure and check with your doctor to make sure that you're not diabetic or pre-diabetic, that you're not having high blood glucose at different times of the day perhaps. But the spasms certainly can be a possibility in the weight loss. The other thing is being a quad is that without using your muscles, your muscles tend to become smaller because they're not being used, and so you can have some muscle wasting, and that will cause you to lose weight because muscle is heavy. It's even heavier than fat. So if you're losing very quickly, you could be losing some muscle, and again, that would actually the spasms actually help you keep muscle. So there's a lot of information in that sentence that you have there, and there's a lot of possibility of what that weight loss could be. But in any event, you've already started with the blood work, so keep up with your healthcare professional to make sure that there's nothing else that's going on in your body that could be causing that. Here we have a person who's writing in who has a father who's had quadriplegia, and they got 2 months of physical therapy. Is there any chance of recovery? His muscles are too weak. He's 66. Well, I will tell you, Partha, I thank you for asking that question because I am a big advocate of people with spinal cord injury. I do think recovery is near. Now, I know people from other countries sometimes, think, in the United States, if you have a spinal cord injury, you get therapy and you get all these fabulous treatments. Well, here sitting in the United States, we can say, no, we're pretty much like everybody else. We in our country, our health care is very much controlled by what you can pay for, just as in any other country. And so we work under the insurance system, and so there are parameters. If you have this diagnosis, you get this kind of treatment. It depends on what your insurance policy indicates. So many people, much like you in India, you've had a person who's had a spinal cord injury for 2 years, much like in our country, usually the therapeutic treatment is over by that time. And so what it falls to is family and caretakers to provide the range of motion, the turning, and all of that care that is required by individuals. So is there a chance of recovery? Well, in my personal philosophy, I think there's so many things that are going on right now. I fully expect to see some kind of something in my lifetime. And, I am just living for the day that it would be great if I had no patients anymore because there was just no need for me. That would just be my dream. So anyway, we have to keep up the hope and follow along with all the research that's going on, because there's so much that's going on right now. And as muscles become weaker, the best thing is to keep that range of motion and keep going and working forward. So providing the best care that we can for our family members who have spinal cord injury. So here's a question, and this is a marvelous question. It's perfect for pain. What do you do if your doctor doesn't believe you regarding your pain? Well, if you are telling someone that you have a problem, then they need to pay attention to you. And if you do not have the belief that your doctor doesn't believe you, then it might be time to look for another second opinion, or maybe to find a different practitioner that you have you can develop a personal relationship with, so that they can understand you. I think when you come to your doctor, I think if you come ill-prepared, it usually doesn't seem to go as well as people who become prepared. Now, sometimes people come in with notebooks and all kinds of things, and it just kind of overwhelms them, and it makes it difficult. But if you can record and then summarize, I have pain early in the morning, or I have pain after I eat, or I have pain when my bowel program happens. If you can isolate that and then tell what kind of pain. Does it feel like a nagging pain? Does it feel like an ache? Does it feel like an electrical pain? The more information that you can give, the easier the doctor or the healthcare professional will be able to isolate and get the treatment for you. Pain is a difficult, it's very difficult to treat pain because it is so subjective. I could have a pain and you could have the same pain, but we might rate it differently. So you might say, well, they're going to ask you on a scale of 1 to 10. That's the standard. How's your pain on a scale of 1 to 10? And you might say, I have this really nagging pain. It's at a 2. And I might say, I have this really nagging pain. It's an 8. So it's very subjective into the life of the person. It's also very difficult to treat. So sometimes people tend to ignore pain or not talk about pain because they don't know what else to do about it. It never hurts if you have otherwise a perfect relationship with your doctor. It never hurts to ask them, I've heard about doctors that do nothing but treat pain. Could you give me a referral to a pain specialist? Or could you give me a referral to a person who treats spinal cord injury to talk to them about my pain? If your policy does not cover that kind of treatment, you can request your doctor to petition your insurance company or Medicaid and have them write a letter of medical necessity so that they can go outside of your policy and try to get the special treatment for you. Now, the doctor will write the letter of medical necessity and request. It's better if the doctor writes it or his nurse writes it, because they'll talk the medical lingo and they know what needs to go in the letter of medical necessity. So sometimes I have family members who say, I wrote to my insurance company and I told them I read this article, or I told them that the doctor thinks I need to have this treatment and I can't get this treatment. the insurance company is not going to pay attention to that. They're going to need to know specifically about your case. They're going to know specifically what the expected outcomes are. They're going to know, they need to know specifically in medical terms why you need this special treatment. Now, the answer to the letter of medical necessity that goes from your doctor's office, the response from your payer will come to your home. So, because you're the holder of the policy. So even though your doctor, healthcare provider can request this treatment, the response will come to you as the owner of the policy. So you have to work hand in glove with your healthcare provider, and the minute you get that response, take it to your provider, because usually the first response is denied, just outright. Then they have to come up with a second request. So it's very important that you work, because the timing for the second request will be limited. You only have so many days to respond to their rejection. Maybe on the first chance you just might get an acceptance, but they only have a certain amount of time to do this. So you need to be looking for that letter of response, and you need to get that right away to your physician. So even if you think from your policy you can't get this, there are ways that you can at least try to get these things. So that would be one way. So if you think your doctor is not believing you in your pain, come well prepared. If you don't have a good relationship with your physician or your healthcare provider, you might want to try another person, or you might ask for a specialist about your pain. Maybe your healthcare provider just has never treated neuropathic pain. So those are all things that you can do, and hopefully you have a relationship with your physician that they should welcome that extra input on that with that. We have somebody here. There's another question. Somebody has a question about bowel care after 32 years, but I don't. Here it is. It's down here. Uses a magic bullet with 30 minutes of DigStim. I'm not getting the results like I used to. Any ideas? Well, that's a long time to be doing DigStim. I hope you're using the magic bullet after a meal, when the gastrocolic reflex is the strongest. When you put food into your mouth, your gut starts working. The second it gets in your mouth, it actually starts working the second you start smelling food, but it really gets strong when you start chewing. Your whole organs and your digestive system come alive, and they really start getting strong. So try to use the magic bullet about 20-30 minutes after you eat, and then for the 30 minutes of DigStim, be sure you're inserting your finger far enough. A lot of people think they're doing DigStim, that they're opening the rectum, but they're really not. They're really relaxing the internal sphincter. So you have to get up pretty high and lubricate your finger well and really relax that. Sometimes you'll be able to feel the internal sphincter. That is the one that you're trying to go for there. I hope you're doing that in 3 cycles, so once every 10 minutes. The other thing is, if you're not getting the results that you used to, you might want to look at your diet. You might want to look at if you can add any physical movement, even a range of motion of your legs, to get something, and that can be any time during the day, to get your gut moving better, or adding fiber to your diet. So a lot of times fiber is the thing that's the part that's missing in those bowel programs. Just before we go, because I see time is up, but our thoughts about alternative medicine to treat pain. Alternative medicine is wonderful. Complementary medicine is wonderful. Some people use those different techniques, and they believe in them, and they just work terrifically. There's a lot to do with pain, is a lot to do with our mental status. If you do not believe that alternative or complementary medicine is going to work, then it's not going to work. But if you really believe in it, if you give it an open-minded try, oftentimes it will work. Things like acupuncture has been used in the Eastern countries for centuries, just thousands of years, and it works for them. So, you think if it's been going for that long, it must have something that's working with it. When you take acupuncture and you bring it over here to Western medicine, it surprisingly works for very few people, which is kind of ironic because it's working so well in one country, why wouldn't it work in the other country? And usually it's because people in the other country know it's going to work, and so they accept that fact. Whereas people in this country think, no, it's not going to do a thing for me, and so it doesn't work. So that seems to be the issue with that. I couldn't help but notice all the cupping going on at the Olympics, and I was thinking about that. Cupping is a therapy that comes from more of the part of the Eastern culture, more over in India, and so over in that part of Asia. And they're little glass cups that are heated up and then placed on the skin. And as the cups cool, it creates a suction. And so the idea is that impurities get pulled out of the body and go into these cups. That's the traditional method. Now, the way it's being used in this country is that it says that it stimulates the blood flow to that area. So I'm thinking that's interesting. I've been thinking a lot about this because a lot of people do cupping in this country now, and they find it good. But I think for the Olympic athletes, I think the cupping really only works on the surface of the skin, and it causes a bruise. That's why we saw these perfectly round bruises on the Olympians on their skin. So a bruise is blood vessels that have been broken, and so the blood is mixed in with the tissue. That's why you get a bruise. And so I'm thinking, how does that really help? They say it increases the blood flow. Well, it does make blood flow to the surface of the skin because the cupping doesn't work deep inside the muscles. But it is causing damage to the circulation. So, you kind of have to wonder, how is that helping an athlete's ability? So, again, you have to look at these different reasons why people are doing. If you go back to the original idea of cupping to remove impurities from the body, that seems to make a lot of sense. If you're using cupping to increase circulation, that doesn't seem to make a lot of sense. So a lot of these things are, you have to figure out what you agree with and what you think will work. I think that a combination of using Western medicine and using Eastern medicine, I think is a very valid opportunity. You want to make sure that your healthcare professional knows each and everything that you're doing. If you have a spinal cord injury and you decide to do cupping, you really need to think about skin breakdown because a bruise is really basically a stage 1 pressure sore. So you need, if it's over a bony prominence and you put a bruise there, it's kind of like, you're giving yourself trouble. So, you really have to think these things through and work carefully with your healthcare professional, and then know that it takes a lot of time. It just takes a lot of time to work through these pain issues. I did a column on the 17th about some different things that are coming up in pain. And so I think some of these are very valid things that is really going to be coming into the future as far as pain research, and doing some of these other treatments. Using biofeedback is another thing, which is telling our brain how to turn off that pain sensor in our brain. Right now there's a lot of information out there about using virtual reality to help people with spinal cord injury train to use their muscles. So they're suspended in harnesses, put in a walking position, and they might have some electrodes attached to them moving their body, but they're using the virtual reality glasses so that they're looking at what it's like to be walking through an area, and so as their bodies are moving, they're seeing the earth go by as they're walking down a path or whatever they're doing, and they're just having some outstanding results in retraining movement. This could be also used as a possibility to retrain pain. And reduce the amount of pain. For people with amputees that have phantom pain, they're using mirrors where they set up the mirrors such that the part of the body that maybe has the limb is replicated on the side of the body that does not have the limb. And so it's training the brain to reroute the phantom pain messages into a positive way. So there's a lot of things that are going on, and it's very exciting. Unfortunately, that's a great high note to leave on. Unfortunately, our time is up. But I thank you all for coming today, and I hope you have a wonderful day. I hope all your pain gets taken care of, because it's just not good to have pain. You need to have some comfort. So good luck to you on that. And remember that I am available on Wednesday evenings, or if you would like to email or respond to a blog post in any way, I'm happy to answer your individual questions. So thank you for coming today, and I hope to hear from you soon.
Hi, just want to thank everybody for joining us. And as a reminder, you may read more of Nurse Linda, her posts at christopherreeve.org/nurse, and you may also continue to ask her questions there. And check our website to sign up for September's edition of Ask Nurse Linda, chatting live with her then. So everybody else, have a great day, and thanks for joining us. Bye.
Bye-bye.